I will be talking on simple to complex strabismus. So my job is done easy by Dr. Soumya. She has already covered most of the point. So simple strabismus is not so simple. One has to do a comprehensive ocular examination, including the all 9 cardinal gaze measurement, and patching and amblyopia therapy is must before doing surgery, and this has to be continued even after doing surgery. In cases of IXT, the world is still updating it, to what are the protocols to be followed for the whether to do early surgery or to wait. So it is better to do surgery in cases of IXT after 4 to 5 years of age to get better sensory motor result. Very minimal amount of esotropia, there is no need to correct it. And phonics incision have definitely advantages over limbal incision, and it is surgeon and case to case based preference whether you want to do adjustable or non adjustable. And avoid very large recession and resections in a single eye, because it limits not only the field of action but also causes significant palpable fissure changes. So now coming to deviations from horizontal, whenever you are tackling inferior oblique, always do it symmetrically in both eyes. And in cases of A pattern exotropia or esotropia, avoid bilateral PTSO if there is high stereopsis, because patient can complain diplopia in down gaze if you are doing bilateral PTSO in bifoveal fixator patients. In cases of Helveston syndrome, which is a triad of A pattern XT with superior oblique overaction and DVD, usually surgery involving all the 4 oblique gives us good result. And in management of complex strabismus, beside all this investigation, the other investigations like orbital CT scan, MRI brain, thyroid function test, and tensilon test are required. And it needs extra time for surgery, and one has to think that nomogram do not help in each and every case. Each and every case is different. So in cases of Duane's retraction syndrome, we for all these special syndrome, we use the term congenital cranial disinnervation syndrome, and DRS is one of that. In ortho DRS, just correct the upshoot, and same time you have to maintain the orthotropia in primary position. In cases of exo DRS, one can do a single eye by splitting with LR recession, and depending upon angle, asymmetric or symmetric LR recession is done. So this case of right eye exo-DRS with a large left face turn was corrected with 9 mm of lateral rectus recession with Y split, with good post-op correction and with no face turn. This was case of left ESO-DRS with left head turn corrected with MR recession and lateral rectus Y split without any recession. So in cases of DRS, SRT is advocated to improve the abduction, ocular alignment, and to correct the abnormal head posture, mainly in esotropic DRS. And in this case of left eye DRS, MR recession was done along with Brooks modification of superior rectus transposition to the lateral rectus to improve the abduction and to improve the face turn. Now, Brown syndrome is one of the most complicated case, because whether to treat or not to treat, and surgery is indicated only if there is large hypotropia and anomalous head turn, and usually silicone expander or chicken suture gives somehow better results. Now coming to paralytic strabismus, in cases of third nerve palsy, you have to look for involvement of superior oblique, whether there is any aberrant regeneration, how is the lateral rectus, and whether pupillary involvement is there or not. In cases of sixth nerve palsy and third nerve, you have to see whether globe is crossing the midline, whether palsy is partial or complete, and how are the saccades. And transposition surgeries are advocated whenever there is no resolution and no improvement after 6 months of the paralysis. So in cases of sixth nerve palsy, the commonly done surgery is Hammersheim Jensen procedure. Hammersheim can be augmented by single augmentation by resection or with double augmentation by intermuscular augmentation. SRT with medial rectus recession also gives good result, and Nishida procedure is also no split, no tenotomy, and it is done whenever there is risk of anterior segment ischemia. So most of the studies shows that whatever augmentation you are doing, it is always helpful in not only improving the angle of deviation but also in improving the binocular field and abduction. So this is a short video on the journey of Botox to the double augmentation. In initial stages, you can give the Botox, and later you have to rely on this transposition surgery. So in this case, the superior rectus was isolated, and it is split into two halves up to 10 millimeter from the insertion, and then 6 cervical suture is passed, and this half is disinserted and attached near the lateral rectus, superior border of lateral rectus. Similarly, inferior rectus is also isolated and it is attached near the lower border of lateral rectus. In cases of augmented Hammersheim, after isolating the superior rectus and inferior rectus, we pass suture at around 4 millimeter from the insertion, and then this superior lateral half is then transposed to the lateral rectus, and the resection can be done prior to it or after attaching the half to the lateral rectus. Similarly, inferior rectus is also isolated. Inferior rectus is also isolated, and it is attached. Resection can be done, and it is attached at the lower border of the lateral rectus. So in this particular case, bilateral augmented Hammersheim along with MR recession was done to treat the traumatic large angle sixth nerve palsy. In cases of third nerve palsy, periosteal fixation of lateral rectus is done whenever there is large exotropia. And a new modality of treatment which is very useful is medial transposition of split lateral rectus, which is given by Gogitz. The only problem is that it can cause choroidal effusion, so one has to be careful. One has need not to pull both the ends very tight. So this video is of split lateral rectus. The lateral rectus is split into two halves, and then superior rectus is isolated. Superior oblique is isolated, and then posterior tenectomy of the superior oblique is done, and the superior half of the lateral rectus is then passed below the superior rectus, and then it is transposed near the medial rectus. Similarly, the uh, other half of the inferior half of the lateral rectus is also taken and passed below the inferior rectus, and it is placed near the medial rectus. So this in this case of traumatic third nerve palsy, NTS-SLR was done with good result. In cases of bilateral superior oblique palsy, one has to see whether there is any reversal of R by L or L by R, and one has to look for arrowhead pattern. So in this case, bilateral IO recession along with 9 mm LR recession gave us a good cosmetic result. In cases of large angle exotropia, modified Nishida can be done, because whenever you are involving multiple muscle, it prevents the anterior segment ischemia. In case of MED, which is a restrictive cause, double augmentation and NAPS procedure is usually helpful whenever FGT is negative and inferior rectus is not tight. And in cases of lost inferior rectus muscle or partial avulsion, one has to look for the careful sections of CT scan to look whether the inferior rectus is attached or it is lost. And this case presented to us after 2 years of trauma, and we did inverse snap procedure to correct the hypertropia. This is one rare case in which the hypoplasia of inferior rectus was seen, and in MRI, the cross-sectional area was very less for inferior rectus, and it was treated with inferior oblique anterior transposition to correct the hypertropia of 30 prism L by R. In cases of high myopia, Yokohama procedure is usually done, in which superior rectus and lateral rectus myopexy is done. While in cases of exotropia, hypotropia complex in high myopia, nasal loop myopexy of superior rectus and medial rectus can be done at 8 millimeter away from the insertion to prevent the sagging of the eye and to improve the limitation of abduction. Now, coming to last slide, these cases are very complexes, and the table itself shows that to remember that which type of CFEM we are dealing with. Sometimes it is difficult to diagnose, and whatever surgery we do, we are always ended up with dissatisfaction and undercorrection. So these are very difficult to treat, and one has to approach very meticulously. So thus, a meticulous planning and planning in each and every case can give patient a cosmetic correction, can improve the quality of life, and patient can have a diplopia free field. Yeah, thank you for this.
Thank you for dealing with so many complex cases. It's always a difficult job when you when these present to you, because obviously you cannot give them the free movements that they want, and the main aim is just to get them into orthotropia and counsel them obviously what is going to happen, like maybe in Hummel schemes or anything. You might uh, give them a little bit of abduction in those cases with six nerve palsies, but yes, the full range is quite difficult, and then probably augmenting it with the Botox, as you rightly said, I mean, some of these cases. So I mean, it no doubt, I mean, we don't have so many cases, but yes, when they present to us, one really has to gauge what is going on, like a periosteal fixation, what you're saying in third nerve, versus a lateral rectus transposition. So that again is not an easy procedure to do.
Yeah,
So again, in those cases also, the patient is not going to have any movements except maybe a straight eye.
yeah, it takes
So
time also, and we are also afraid whether we are not going to give any new tropias to the patient and some new thing to.
yes, I mean, they're usually large angles when they present with third nerve palsy. So probably a neutropia would be you can less of a chance, as rather than giving them what they want. I mean, they'll be much happy with the surgery what you've done. But yes, the lateral rectus should not be tight in these cases, and even you could do a superior and inferior oblique tenotomies and just go around and augment these sutures depending upon the deviations. What I think has been described by Rohit Saxena as well, because we had failures in our series when we did a lateral rectus transposition for 90 prism diopters. We had to do a medial rectus plication, even though it was a palsied muscle because of third nerve palsy, but then just a tightening procedure to get the child into ortho. So I mean, from case to case basis, you have to do all these procedures, and it's a nice illustration. Thank you.